Thanks, Natasha. Is this sound good for everybody? Okay, great. So she mentioned I'm the medical director of the Barton Hospital Sleep Lab, where we actually have 2 beds. We do sleep studies 7 nights a week. And so it's a little community outreach, talk a little bit about sleep. I've been doing sleep medicine for about 20 years now, and I do a variety of other specialties in general internal medicine and critical care and pulmonary medicine. So I see a lot of different things. This is really my passion because, if you see somebody with high blood pressure and you treat their blood pressure, yeah, it's a little better. They might not have a stroke in 10 years or 20 years, or they might not. You don't know. If you fix a sleep problem, you can really have a huge impact on somebody's life, and sometimes it can be life-changing. And I could spend the whole hour just telling you stories like that, but I think we'd be more productive. So I'm going to go over some of the basics of sleep, and more importantly, what happens when you don't get sleep. Because everybody knows, hey, when I sleep good, I feel great. That's a short conversation. So this will be more about when things don't go right. There's a whole variety of sleep disorders. The list is very, very long. The vast majority of what we see in the sleep clinic are 2 things, insomnia and sleep apnea. So the emphasis is going to be on that. I like to keep it interactive. If you have a short, quick question, great. If you want to talk about your own personal history of insomnia, that should probably wait till later. But please feel free to interrupt, ask any questions as we go through all this. I guess it's that button. So why is sleep important? Well, it's important for what happens when you don't have it. Again, everybody knows what normal sleep is. You lay down, you wake up, you got sheet creases in your face, you look good, you move on. What happens when you don't have adequate sleep? Well, the list is huge. Mood disorder is very common, depression. I see a lot of people with complaints of depression. They don't really have depression, they have sleep deprivation. Symptoms are very similar. We know that people have a high risk of cancer, premature death, shorter lifespans, metabolic syndrome, obesity, high blood pressure. The list just goes on and on and on. So to summarize it at the bottom, you get sick, fat, and stupid. So it's important. We want to fix this. And the good news is most of the time we can. Well, how much sleep do you need? This is a common question. It's a common conversation. You can see as time goes on, we need less and less. Newborns, infants, they sleep all the time. As we get older, less and less sleep. This is a really important factor here with teens. This is a very common cause of conflict in families. You're so lazy, you're sleeping all the time. Get out of bed, it's time to go to school. The reality is that teenagers have a different sleep cycle than adults. But adults run the world, so we try to push them into our schedule. What ends up happening is their sleep rhythm is offset from ours. They want to go to bed 9, 10, 11, 12 o'clock, much, much later than we do. Consequently, needing 9 or 10 hours of sleep, they want to sleep till 8, 9, 10 in the morning. It's not laziness, it's just what they need. Fortunately, a lot of the school districts are now recognizing this, and they're moving towards later start times for students. It'd be like asking you, get out of bed 4 a.m. and go to work. You'd be like, can I keep a couple more hours of sleep? And so that's really important to recognize with kids. Adults, 7 to 9 hours a day. We told this to patients for years and years and years. Hey doc, how much sleep do we need? Yeah, I guess 7 to 9 hours, that sounds right. Well, this past year they had this big consensus conference. All the world sleep scientists got together in Madrid. They apparently had a good time, 4 days, to answer this one question. Well, actually it wasn't one question, they looked at all this. So after 4 days, they compared all the science, all the great research, and they came out with this very important consensus paper, high-level research. What'd they come up with? Yeah, you need 7 to 9 hours a day. So they got a nice vacation out of it. This doesn't project very well, but essentially this is just a depiction of the different proportions of sleep as we get, or that we get as time goes on. So infants, majority of their day is in sleep. So this is wake, that's REM sleep, and that's non-REM sleep. And you can see they spend more time asleep than awake. They get huge proportions of REM. REM is a very important stage of sleep in brain development and brain recovery. So infants are using it to develop their brains. They're just sucking in information. Their brains are growing and they're just, they're progressing day by day. In older folks, it's brain recovery. It's the way our brain rests. It's the way it repairs itself. We don't really understand a lot about what REM is. We understand what happens when you don't have it. So as you can see, as life goes on, we have more wake time, less sleep time, and less REM. Very challenging as we get older, like, well, a lot of other things. What's basketball have to do with it? So this guy, Steph Curry, you probably heard of him. Very good basketball player. He has some innate ability. Sure, he's nurtured it, he's practiced it, he's made himself as good as he can be, but he was born with some natural abilities that make him a great basketball player. As opposed to Will Ferris, who is still trying to do free throws underhand, right? So what's that got to do with sleep? Well, it's the same type of thing. Everybody has differing abilities to sleep. There are the people that just lay down at 10, they wake up 8 hours later, they feel great. And then there are other people who have a lifelong struggle with sleep. And it's really hard to get them to understand that this is just not what you're good at. We're going to work with you, we're going to try to make you as good as you can be, but you're not going to be slam dunk in the NBA. We have to get you enough sleep so you can function. And that brings us to insomnia, which is a very common sleep complaint. It's not always the same thing. So insomnia can be, gee, I just can't fall asleep. Once I get to sleep, I'm good. Or gee, I fall asleep just fine, but then I wake up and I'm up all night and I'm tossing and turning. Or, you know, I sleep, but I just don't feel good. It's always light sleep. I'm tossing, I'm turning. It's never really good for me. And these can be associated with very significant symptoms of distress and impaired function during the daytime. How common is it? Well, it's really common. Most common complaint in the industrialized world, sleep complaint. 30 to 40% of people at some point in their life have not just like one night, but a significant bout of insomnia, one that does lead to impairment and distress. 8 to 19% of those folks. And why is it more common in women? It's an interesting question, and as a man, I probably shouldn't answer it, but this is the best explanation I can come up with. And it's silly, but come on, it's true. You know it's true, right? You know it's true. And I'll touch a little bit more later on what's specific for women and insomnia. So what happens? Again, this is all pretty obvious stuff. You know, poor fatigue, poor work performance, sleepiness, somatic complaints. I ache, I hurt, I have headaches. Those are actually physical symptoms that can be as a result of poor sleep. Because again, that non-REM sleep is what restores us physically. Remember, the REM sleep restores us mentally. Mood disturbances, we talked about that. Poor concentration, being face down on your laptop. Hopefully at home, not at work, but although I think maybe she's a telemarketer, so that was merciful. And of course, impaired performance. You can't do anything well when you're tired. You can do it, you just can't do it well. So what happens to the doctor's office? This is rather old data. I think it's still pretty true. It's certainly true in my experience, because again, I do primary care as well as in sleep medicine. So this is a survey done. I think they had like over 1,200 patients. It was fairly large. 69% of, these are chronic insomniacs. These aren't people that just have one bad night. These are people that have been suffering with this for years, right? 69% of them never brought it up to their doctors. The other ones, 26%, about a quarter, they were there for this or that and the other thing. Oh, by the way, doc, I'm not sleeping very good. And then only 5% come in to say, hey, this is my problem. I used to call this the door handle complaint. Like we talked about whatever, this and that, the rash, the itchies, the headaches, whatever. Walking out the exam room door, oh, by the way, doc, I don't sleep. Well, what's the problem with that? Well, first off, we don't have time to address the issue. Secondly, it's a reflexive thing. Oh, here's a sleeping pill. And we don't address the problem. We don't figure out why they're not sleeping well. It's complicated. Insomnia is very complicated. There's many factors to go into it. Stressors, certain medications. I'll talk a little bit more about that. Circadian factors, when your body's programmed to go to bed, when your body's programmed to wake up. Medical conditions, psychiatric disorders, mood disturbances, behavioral factors. We'll talk a lot about that. Age, remember it gets harder as we get older. I know it's news to a lot of you folks in the room, maybe not. And then primary sleep pathology, something like sleep apnea, restless leg syndrome. So this is not a doorknob question for the doctor. This is like, I want to go in and figure out what's going on. This is a very common type of insomnia. It's called psychophysiologic insomnia. Why? Doctors like big words. It makes us feel smart. But what happens is you have some issue that keeps you from either initiating sleep or maintaining sleep. So what do? You get frustrated. God, it's 3 o'clock. Now it's 3:10. Oh, Jesus, 3:15. I got to go to work. So that frustration and that fear leads to psychological activation. Essentially, you get awake, right? Nobody goes to sleep when they're raging mad, when they're frustrated. That leads to some bad behaviors, which again, we're going to talk about. oh, well, I'll get out my laptop and distract myself with my favorite book or my movie or Facebook or whatever. Bad behaviors, which of course leads to this, and the cycle goes round and round, and then you end up like that. This is very interesting. This is actually a very old research study, and I've been showing this slide for years, and I've never really figured out how the time bar works here. So just kind of ignore that and just pretend this is a 24-hour cycle. So what's really interesting about this is they compared the metabolic activities of people who are chronic insomniacs versus folks who are quote-unquote normal, a little harder to define. And what they found is across the board that chronic insomniacs, and these are people cradle to grave that don't sleep well, not somebody who just has a bad week or two, their basal metabolic rate is higher throughout the day. And we haven't really made the correlation of why that fits, but it makes sense. If your motor's running faster, it's harder to sleep, right? And that goes on throughout the day and during the night. So again, if your metabolism's running faster, the motor's running faster, you're not going to sleep as well. So what happens to the people that are not chronic insomniacs? So most of us hopefully live here. Here's insomnia, okay? When you get above that yellow line, you're not sleeping. When you're below that yellow line, you're sleeping. So acute insomnia happens, and it can be from anything. Pick a stressor, pick a thing, pick a whatever. Suddenly we can't sleep well. Well, typically that will resolve itself through whatever means, and we go back to being here. And this is what most people have experienced at some point in their life. A brief period, not sleeping well, it resolves, I fix it, whatever, you go back to sleep. But here, this is the psychophysiologic thing, that you have perpetuating factors, that you've developed adapted and maladaptive behaviors, and you perpetuate your sleep. Or there can be a medical condition, or there can be depression, or there can be something else that disrupts your sleep that actually perpetuates it. These are the folks I want to see, because these are the folks we can help. These folks kind of fix themselves, and well, these folks don't even need me. How do we approach this? Very simplistic diagram, but it totally makes sense. First thing, you talk to the patient. You take this long history, and we'll get into some of the things we look at about their life, their sleep habits, et cetera, et cetera. This is huge, and this is the handout that we had for you. 90% of sleep problems can be fixed just with that one piece of paper, if you follow the rule book. All those things on there you look at and say, well, yeah, that makes sense, but then you talk to people if they're doing them. Well, yeah, except I get my laptop out for an hour and I get on Facebook. Well, that's not part of it. So sleep hygiene and education are a huge part of it. When that's not working, you get down into, do you use medications? Medications do have a role for sure, but there's also non-pharmacologic ways of approaching it. And again, I'll talk about that a little bit more as well. Understanding some of the problems and long-term problems with long-term use of sleep medications, we're really trying to get over here and use this as little as possible. And when nothing else is working, then you go see the person that has more experience using it. Most primary care doctors should be able to do this for you. So what am I looking for? Well, first off, the history. Again, did this start when you're in high school? Everybody sleeps good in high school. It's the best sleep ever, right? If they say, yeah, I didn't sleep good in high school, I was just up and down. So, and it's been that way their whole life. I've got a chronic insomniac. And you approach that a little differently. I go back to the Steph Curry, Will Ferrell slide, and I show them that, and they walk out mad. But it's really important to find out how long this is going on. Did something set it off? Was there some big life event, some big trauma, some big psychological thing, some stressor, some initiating factor? Hey, I slept great until this happened, and I haven't slept well since. It's a different approach to that. Look for primary sleep disorders. Common ones are restless leg syndrome. It's a really bizarre disorder. People have this sensation of, I just got to move my legs. And the moment they don't, they get this very uncomfortable sensation. And the number of descriptors is about this long. Creepy, crawly, achy, prickly, restless. It only goes away when they move their legs. Well, how many people can fall asleep while they're kicking their legs? Not too many. And again, we approach that differently. Or do they have sleep apnea? Even though insomnia is not an indication for being in the sleep lab, a lot of times poor sleep is actually because you're not breathing at night. And again, we'll review sleep apnea a little bit. Daytime symptoms, super important. Interesting thing about chronic insomniacs is even though they never sleep well, they haven't slept well their whole life, they're not that tired. They can function, they can hold jobs. They're just mostly irritated because I'm not doing what everybody else is doing. Everybody else is sleeping and I'm laying there. But interestingly, chronic insomniacs are not tired. Conversely, if somebody says, man, I'm a truck driver and I have to stop 5 times to get a cup of coffee and I'm falling asleep at the wheel, whole different story. And that kind of brings you back to, is this insomnia? Is this sleep apnea? Is this another disorder? Sleep habits. This is super, super important. I'll show you a little sample of a sleep log here. I have virtually every one of my patients, before you do much of anything, complete a 2-week sleep log. When you go to bed, when you get up, how much caffeine do you have, how much alcohol do you have, put the naps in there. And I'll talk a little bit more about that in a minute. Medical, neurological, psychiatric history, huge. I mean, there's so many medicines out there nowadays. Virtually everybody's on something. And a lot of these are obvious things that disrupt sleep, and a lot of them are not so obvious to the untrained. There are certain types of medicines for blood pressure that can disrupt sleep, certain medicines for mood that disrupt sleep, and so it's really important to get good medication history. And then, of course, health habits. Do you exercise? Do you eat right? Do you go to bed at the same time? Are you up to date on all your screening stuff? Are there medical issues that haven't been addressed, et cetera, et cetera? So this is why this is not a 5-minute, hey doc, I don't sleep as he's walking out the door question, because to do a good evaluation of this and really to get the root of the problem, not just throw a pill at it, this is what you have to do. Here's an example of a sleep log. So really simplistic: when you go to bed, when you get up, exercise, alcohol, meds. Obviously important to know which meds they're on. Why do this? Well, I know when I go to bed. I go to bed at 10 o'clock every night. I get up at 6 o'clock every morning. Usually not true. For example, everybody probably remembers, if pressed, what did you have for dinner last night? Well, you probably know. What did you have 4 nights ago? I have no idea, right? So if you do this, sometimes you'll recognize patterns. And using the food analogy, if you did this with food, you might realize, gosh, every Thursday night we have pizza. I never realized that before. So sometimes you can recognize maladaptive behaviors with this. And the one that I see very frequently is Monday to Friday. They're going to bed at 11 and getting up at 5. And then Friday and Saturday and Sunday, they're going to bed at midnight and sleep until noon. Oh yeah, I just thought that was normal. So it's very useful in determining, maybe is there a pattern, maybe is there a circadian rhythm thing we can fix, again, without using medications. Well, why can't you sleep? Does this look familiar to anybody? No? Nobody does this in this room, right? Yeah. I mean, how the heck can you sleep? You got papers, you got phones. I don't even, was that a cigar? I'm not even sure what that is. Bright lights, laptop, right? Light is the enemy of sleep. We are entrained. There's an area in our brain, very small area, that is entrained to light cues. And you may even find that throughout the year, during the winter, we tend to want to go to sleep a little earlier. We want to tend to have dinner a little earlier. It's all about the light cycle. And then when summer gets here, oh, heck, it's 8 o'clock, let's have dinner. And you stay up till 11 or 12 o'clock at night, where in the winter you're going to bed much earlier. These are very important cues to the brain when we're supposed to go to sleep and when we're supposed to wake up, because 150 years ago we didn't have light. Light was the sun, and we followed the light cycles. So it's super important to avoid this. Computers put out blue light, very, very bad for sleep. All right. So wonder why you can't sleep? This is one of them. Bed's only for 2 things. You guys can start thinking about what that is. I'm going to give you the answer. There's not going to be any tests. All right. 2 things. Okay. So there's the first one, right? And that's what sleep's supposed to look like. It's not all beautiful and pretty. It's mouth's open, drooling a little bit. And what's the second thing? All right. That's it. That's what bed's for. Fair warning for anybody that ever wants to do their own sleep talk. If you go to the internet and look for a picture of lovemaking in bed, don't do that. I learned some things. It was shocking. But this was a clean one I can come up with. So remember, my professors in college used to do this, a really important point that back up and kind of go over it again. Bed's for 2 things, that and that, period. All right? So how do we address it? I've already alluded to a lot of this. There's the non-pharmacologic approach, and a lot of that is really based on, oops, I pushed my button. There's a non-pharmacologic approach, which is addressing all those things you just talked about, the sleep hygiene thing that is so vitally important, the handout, please everybody take one, share them with your friends. And there's a gazillion resources on the internet. You're going to see the same thing over and over and over and over. Pharmacologic therapy, again, sleep meds do have a role. I'll touch base a little bit on that. And often combined. Often we'll take somebody who's just so far out of whack, they're desperate. We put them on a sleep medicine for a period of time, get them in the zone of sleeping, get their sleep cycles back in place, while we're employing the non-pharmacologic things and teaching them how to sleep better, teaching them how to use their own innate rhythms. It's kind of like using the force, It's already there, you just got to let it happen. And that's the same thing with sleep. It's already there. You just got to quit screwing it up. So this is one approach. I've had very little success with that, but it's time-honored, so I had to put some sheep in there because they've been part of sleep medicine since it was born. It's kind of an interesting aside, sleep medicine is actually a very new field. It wasn't until the 1940s that we even understood that sleep was anything. It was this passive thing. Yeah, nothing happens, they're asleep, and we studied things while they're awake. And there's these two researchers that actually, they were neurologists. They said, well, let's see what happens with brain waves while people are asleep. It's like, there's some stuff going on. And in this lab, they actually described the stages of sleep based on brain waves and muscle activity. One of those researchers was named William Dement. William Dement is still alive today. So the guy that first described REM sleep, which everybody's heard of, he's still alive. He's a professor emeritus. He's still at Stanford. He's a god to everybody in sleep. So it's a very, very new field. One of the other interesting things that came out of that is that these brainwave activities, we divided up into essentially 4 stages of sleep. And what we found is that if we selectively deprive people of one of these certain stages, and we used to do this when I was at Stanford myself, and we used to do this in the sleep lab, we get medical students because, well, they're there, they're willing, they're really cheap, they're willing to please. And what we'd do is we'd torture them. So we'd essentially selectively deprive them of one stage of sleep for a series of nights in the sleep lab. Every time they'd get in a certain stage of sleep, they had this little buzzer on their toe, just enough to disrupt the sleep, not for them to go, ow, stop that. And we do that for several nights in one stage of sleep. Then you let them sleep, and what you'd see is a huge amount of that selective stage of sleep in the subsequent nights. So even though this was an artificial thing that some neurologists looked at from brainwave activity, it appears that the body actually recognizes these separate stages of sleep. That's kind of science geek stuff. I don't know, you guys are all going, what? Yeah. It was interesting to me. So how do we approach it? These are the non-pharmacologic treatments. And a lot of these are behavioral treatments, and that's what's hard. We're busy, we got stuff to do. Give me a pill, make this better. I don't have to work at this. Really, there's a pill. My neighbor takes this pill. He says it's great. He gave me one. I slept great. But the reality is, these are the hard work, or this is the hard work, and this is the stuff that pays off. So sleep hygiene, I'm beating that thing to death because it's so important. Stimulus control, right? Just like the guy in bed with the phone and the computer and all that. You can't have that stuff in your bedroom. Your bedroom has to be a quiet, dark, safe, comfortable place. If it's a place of problem solving, it's a place of arguing with your spouse, of playing with your kid, of getting on your computer, in your subconscious, then that's what bed is for, and it's an activated place. So bed's got to be for those two things we talked about. And so getting people to change their habits is very difficult. Oh, I can't not have my phone next to my bed. Why not? We lived for millennia without phones, It's really not that important, especially if you're having trouble. Sleep restriction. This is kind of an extreme approach. I call this sleep boot camp. So for instance, somebody says, Doc, I only sleep 4 hours a night. It's like, really? Well, how much time do you spend in bed? Oh, I'm in there 8 hours. I got to get 8 hours of sleep. I said, well, you just said 4 hours. Well, yeah, I only get 4 hours. Okay, so from here on out, you only get 4.5 hours in bed. So you pick your bedtime, you pick your wake time. Like, what? I'm not going to sleep. It's like, yes, you are, because you only got 4 hours to do it. So the idea there is to consolidate time in bed. So when you're in bed, you should be sleeping. If you're not, you get out. Oh, wow, it was great. I slept 5 hours last week. Super. Then you extend the time to 5.5 hours, and you keep extending it out. And again, the idea is to consolidate time in bed for sleep alone. Because again, too much time spent in bed flopping around and doing other things is non-productive and actually counterproductive. The brain gets used to that. So if the brain understands, this is the only time I get sleep, it tends to happen. It takes a lot of discipline to do this. I've had some success with it in a few patients, but they really have to be committed and they really have to be disciplined. Oop, keep pushing the wrong button, sorry. Cognitive therapy. This is unfortunately something we don't have resources locally. There's a thing called cognitive behavioral therapy, usually run by psychologists that kind of go through the whole thing, look at life issues, counseling. It really does work. It's very effective. This is actually more effective than sleep medicine. There's a lady in Reno that does this sort of thing. Insurance doesn't pay for it. And again, interestingly, people will buy new cars and new phones, but they won't spend money to fix their sleep problem. But it is an effective treatment. And the last one is circadian rhythm entrainment. Gosh, Doc, I am in bed every night and I don't fall asleep till 2 in the morning. Well, what time do you get up? Well, I got to be at work at 5, I'm exhausted. Well, what do you do on the weekends? Oh God, I sleep till 10. I said, so have you been on a vacation? Yeah, I go on vacations. I said, when you go to bed? Oh yeah, it's great. I go to bed at 2 and I get up at 10 every day. It's wonderful. These people have what we call delayed circadian rhythms. So essentially their cycle is just shifted. So their normal sleep cycle is to go to bed at 2 and get up at 10. They're still getting 8 hours of sleep. But again, like those poor teenagers, we're trying to kind of stuff them into that 10 to 6 box. You can fix that. It's very difficult. It takes a lot of work and an extreme amount of discipline. They're bright light therapy, so you get up at the time you're supposed to get up. They have these commercially available big light boxes you're supposed to sit in front of for 45 minutes. And then the reverse happens on the night before. So getting closer to bedtime is going to be dim and quiet and dark and try to get that light cycle going. Another way of fixing it, which is extremely difficult, is you keep advancing their sleep cycle. So okay, tonight you're going to go to bed at 2:30. You're going to do that for 3 nights and get up at 10:30. And then 3 nights later, 3 a.m. to 11 a.m. And you got to do that all the way through the clock until you get to 10 p.m. And the moment you deviate from it, you start over. To date, after 20 years, I've never had a patient successfully do it. I mention it for interest, but it's really not practical. So these are the non-pharmacologic approaches, and sometimes it's a combination of things too. It's not like, oh, you got to pick one and that's it. You can combine relaxation training, biofeedback. I don't know if you guys are familiar with that. It's this very kind of regimented process where you actually learn to control the things in your body that you usually think about, breathing and heart rate and blood pressure. And once people get the ability to control these autonomic processes, sleep falls into place. So once they control the activation, that excitement in their brain, and they calm it down, they bring it down, it can be very effective. And again, it's non-pharmacologic. Most acupuncturists are very well versed in this because it's a huge part of their business, is seeing patients who don't want to do medicines, but do want to find ways of sleeping well. So the bottom line is you can combine these. You combine that with sleep hygiene, behavioral therapy, et cetera, et cetera. Sleep hygiene, okay? We stole this because the dentists have been using it for years. Dental hygiene, everybody knows what that is, right? You got to floss, you got to brush. Well, why do you do all that? Well, you want your teeth to be nice, you want them to work well, you want them to last, you want them to fall out. Sleep hygiene is the same thing. It's a little more complicated than just flossing your teeth. Regular sleep and wake cycles. That classic sleep pattern I told you about in the sleep log, oh yeah, I sleep 6 hours during the week and 12 hours on the weekend, it doesn't work. You want to get out of bed at the same time every day. That's the most important part. The bedtime's not quite as important because you really don't want to go to bed until you're tired. But getting up at the same time, again, helps set that circadian rhythm, that sleep cycle. Avoid stimulants and stimulating behavior. Yeah, I have a cup of coffee with dinner. Well, yeah. But alcohol, alcohol's thought of, oh, alcohol is great, it helps you sleep. It really doesn't, it disrupts sleep. You have to avoid stimulating behavior. Oh, I love to work out right before I go to bed. Well, it's great for your exercise, which is important, but it's not going to work. Bedtime routine, it's got to be a kind of journey into twilight. You don't want to go from going a million miles an hour and trying to get everything done for your next day and then jumping in bed, because what's going to happen? You're not going to sleep. So you have downtime. You have that transition from the day to the night. Reading, dim lights, relaxation, music, that sort of stuff. Kind of gears your brain up for sleep. Oop, my teeth. No. Conducive sleep environment. So that's your bedroom. And it's a big problem with married people because almost inevitably one person wants the bed warm, one person wants the bed cold, one person wants the window open, one wants it closed. But you got to find that compromise. Your bedroom's got to be adequate temperature, comfortable, quiet, dark. I see people, I ask them about their beds. I said, what kind of bed? Oh, I got a California King. I said, I thought you were single. Oh yeah, well I got 3 dogs and a cat, and they're all in the bed. It's like, well, okay, So it's got to be a good sleep environment. And these sound silly. These are real stories. And I talk to people about this stuff every day. Limiting daytime naps, it's kind of an old trick question. You ask the audience, oh, is napping bad? Oh yeah, it's bad, you shouldn't nap. Reality is if you're sleeping well at night, a daytime nap is perfectly fine. It actually feels pretty good. It should be less than 30 to 40 minutes, and only if you're not sleeping well. If you're sleeping terrible, oh, I had a horrible night, then you sleep for 2 hours in the afternoon. Now your body's confused, like, wait, I was sleeping, now I'm awake, then I was sleeping, and now I'm supposed to go to sleep again. Naps are really bad for in training that circadian rhythm that we need to do to sleep well. Alcohol and caffeine. I have 3 cups of coffee in the morning and none the rest of the day. That couldn't be the problem. Well, actually, yeah, it could. Some people metabolize it very slowly. Some people are very sensitive to that stimulant effect of caffeine. So I usually try to get people to reduce their caffeine intake by half as a first measure. Because people are drinking 3 or 4 cups of coffee a day. If you make them stop, they're really going to hate you, right? So, variety of ways. You can just reduce the consumption by half, or you go to half caff, so you still get your caffeine. And a lot of times it'll work. It's like, really? I guess it was the caffeine. And again, we're a caffeinated society. I mean, go to Starbucks at 2 or 3 in the afternoon, it's packed, right? Why is it packed? We all have another dip in our circadian rhythm in the middle of the afternoon. People commonly attribute it to lunch. Oh, it's because I had lunch, it made me tired. We have 2 big dips in our rhythm, 2 big sleep times. One's about 3 in the morning, and the other's about 3 in the afternoon. The one in 3 in the afternoon is a little less deep. In Europe, they're smart. They say, well, we're closing for a couple hours. They go home, they take a nap, they come back. Here, we go to Starbucks. So go to Starbucks in the middle of the afternoon, everybody's trying to fight that little dip. Anyway, caffeine, not so good. Alcohol, really bad. More on that. Regular exercise, benefits of exercise are obvious. It also helps sleep. The science shows people who exercise regularly have much easier time falling asleep, staying asleep, and better quality of sleep. Do you have to train for a marathon? No, you go for a 30 or 40-minute walk. You go to the gym for half an hour. You get on an exercise bike, whatever. It doesn't take a lot. You don't have to train for the Olympics, but it really does help you sleep. Clock watching, major evil, major evil. It's a negative feedback loop. It's 3 a.m. It's 3:15. It's 3:30. You're kidding me, right? What's that do? It's activating you. It's making you mad. Remember, we're mad, we're frustrated, we're angry. We're not going to sleep. Take the clock, put it in the drawer. You can still set the alarm. You can set the alarm and put it across the room. Clock watching is really a negative influence on good sleep. And then electronic tasks well before bedtime goes back to the guy with his laptop. A lot of my patients, I'll say, hey, set aside some dedicated time, like right after dinner, and do all that stuff. Think about who you got to call, send your texts, send your emails, make your list, do all that, have a dedicated time. That way when you're laying in bed, oh, I got to call Bob. Oh yeah, it's already out there, it's already done. Again, the idea is, metaphorically, in reality, move that stuff out of the bedroom. It's outside the bedroom. Because you remember, what's bed for? 2 things? Okay, good, that's great. So if you don't do all this stuff, like the guy who doesn't floss his teeth, what do you get? Well, you get bad teeth, right? You don't want that. That's why we do that's why we do dental hygiene. That's why we should be doing sleep hygiene. So drugs, this is everybody's favorite thing because we all want a pill just to fix our problem, right? There's got to be a pill for this, right? They don't have to work. Every day people in a doctor's office, I want a weight loss pill. Well, that doesn't really exist. It's hard work. But there are pills for sleep, and there are times to use pills for sleep, and we do this actually quite a bit. So this kind of situation, yeah, absolutely. You need some sleeping pills. Your emotions are a wreck, your life is a wreck, absolutely. But it's for a period of time. It's not meant to be for the rest of your life. Predictable stress, I never sleep before an exam, and of course we know the cognitive function, the ability to take a test, pass a test, is drastically impaired if you don't get good sleep. Shift work, jet lag, a little more complicated, but we can definitely use it for those circumstances. And then even sometimes in chronic insomnia, you said, hey, you just told me I'm not supposed to take a pill all the time. There are a certain number of patients who actually do have a good indication for taking sleeping pills every single night. You say, well, that sounds really bad. Well, it is, but the flip side is that chronic sleep deprivation, just like we saw in one of those first slides, has a lot of downsides. And so even though these pills have a lot of potential complications and long-term effects, so does chronic sleep deprivation. But these folks need to be selected very carefully. They need to be counseled extensively. They need to be monitored carefully because these things are not without risk. I love this slide. This was from an ad for Lunesta that came out many years ago. And I love this. This is great marketing. This is so good. This is normal sleep. You should have perfect makeup and a Mona Lisa smile on your face, and your hair should be perfect, and there should be butterflies, and it should be all wonderful. Because if you don't sleep like this, there's something wrong with you, and you need the drug, right? So it's great marketing. Unfortunately, it's not true. That's not normal sleep. People don't sleep like that. Look at your bed partner sometime when they're asleep going, it doesn't look like that. So what do we use? And the really sad part, this is a partial list. This is not a complete list of all sleep meds out there. It's much, much longer than this. But, Matrix, you need a chill pill. And sometimes you do. There is no perfect sleep pill. All of these medicines have risks and benefits. All of them have indications, patients we should use them in, and all of them have complications in patients we shouldn't use them in. Some of the older ones, the benzodiazepines, you may have heard of some of these things. They're all in the same class as Valium. They hit what are called GABA receptors in the brain, which are specific sleep receptors. They're like switches for sleep. You turn these receptors on, you get sleep. The problem with these medicines is they also hit a lot of other things in the body. I tend to use these types of medicines for my patients that have a lot of anxiety that's keeping them from sleeping, because again, remember, Valium, it's the chill pill. Long-term use of these has been associated with some bad stuff, dementia, chronic memory loss, which is not reversible. So again, we use these with a great deal of caution and a great deal of monitoring. These are the newer ones. You probably all heard of these, right, because they were all over the TV and news a while back. Ambien, Lunesta, and Sonata. Very similar. They're much more specific GABA receptors, so they don't hit as many other receptors in the brain. The addiction potential is much, much lower with these. It still can happen. Addiction potential with these, particularly this guy, is very high. I virtually never prescribe Xanax. It's just not a good drug. These guys are much more selective. They work well. But again, they've also been associated with risk of long-term memory loss and dementia, and so we use them with caution. When the FDA first approved this one, Ambien, they approved it for intermittent insomnia because nobody ever had a thought that people were going to be taking this all night, every night for the rest of their lives, right? But say, every time I take this pill, I sleep great, so I'm just going to take it forever. Well, after now about 15, 20 years of Ambien, we're seeing some long-term side effects, and there's a big push to get people away from these. Definitely shouldn't be used in older people, and just for the audience, I didn't come up with this, the FDA describes elderly as 65 and above. I don't agree, especially around here, but yeah, so for our older patients, you really should stay away from these. This is the over-the-counter stuff, Benadryl. It's interesting, if you go down the allergy aisle and you pick up a box, and you walk over to the sleep aisle and you pick up a box and you look at the ingredients, they're the same. These are antihistamines. So histamine is a activating neurochemical in the brain. The more histamine you have circulating in neurons, the more awake you are. So this is antihistamine, that's why we sleep. Lots of side effects. Hangover effect, you wake up in the morning, you still feel like it's there. Dry mouth, urinary retention, there's a lot of issues. And again, in older patients, keep taking more of this because they want to sleep better. You can see hallucinations, behavioral problems, and sometimes it's hard to figure out. It's like, why is he acting so strange? And then you go to his medicine cabinet, he's got a Costco jug of Benadryl he's been taking every night. And I've seen that too. These are older antidepressants. We rarely use them for depression anymore. This one in particular is what the FDA wants us using for the elderly for sleep. The problem is that it was a generic medicine. A company got a patent on it. The normal dosage was 10 milligrams. The FDA approved 3 to 6 milligrams. So a drug company bought the license on it. They make 3 to 6 milligram capsules that cost about $300 a month. So send that to your insurance. The insurance says no. So the insurance says, oh, don't use this on Mrs. Smith. She's over 65, but we're not going to pay for that. You know, what do you do? Remeron's an old drug. This is a very interesting drug. Note the name, Remeron. It's one of the 2 drugs out there that actually increase REM sleep. And this is actually a really good sleep medicine. It's very effective. It's very sedating. It doesn't really leave a hangover effect. There's no abuse potential. And you have a question? No. Oh, yeah. Well, it's an older drug. Metirazine is the trade name for it. The downside, which a lot of people don't like, is it can lead to weight gain, and not just like a few pounds, but a lot of pounds. Herbal remedies. This stuff gets a lot of play and a lot of press. Go to the internet. Oh, melatonin, valerian root. I have patients come in, they swear 6 ways to Tuesday. This med works, I sleep great, it's perfect, it's herbal, it's non-toxic. Great. You look at the science, it doesn't work. Valerian root doesn't work. You know, placebo-controlled trials. But again, if a patient comes in, they're taking an herbal supplement and they swear by it, great. Melatonin does have a role. It helps kind of reset that circadian rhythm in the brain. So it works well for jet lag. It helps kind of reset that circadian clock. So here's something you guys got to remember. I didn't write it down. If you're traveling somewhere else, somewhere east, you take 3 milligrams at 7 p.m. local time for 3 days. It will help reduce the jet lag effect by about 1 hour. So it helps a little bit. It's not magical. Going west is actually relatively easy. Going east is really hard. Antipsychotics. Now we're getting to the big boys. Very rarely used. It is very sedating. Yes?
Back on melatonin, wasn't there a study that showed that, long-term use was causing some problems? Is that not true?
Well, it's difficult with these herbal remedies because they're considered foodstuffs. So the quantity, the concentration, et cetera, is not well regulated. And so it's really hard to do good studies on these things because you can pick up a jar of this at the health food store, and right next to it's a jar that's completely different. So I'm not aware of those, but I wouldn't be surprised. The other problem with a lot of the herbal remedies is they're made in China because it's cheap, and they've done analysis on these things. Just going into Walgreens and pull these things off the shelf, they're finding that what it says on the labels, not necessarily what's in there, and also that you find bad stuff like heavy metals, et cetera. So I tell my patients, if you really want to do these things, try to get something that's at least manufactured in the United States so there's some QA. But I'm not aware of that. And now I got more work to do. I got to go look. There's a new drug class. You've probably seen this one on TV. It's a lady with a cat that's like running around her legs. It's called Balsamra. This is a very, very interesting approach, and we were hoping it was going to be a big breakthrough. Unlike antihistamines or GABA receptor agonists, these aren't trying to hit switches that make you sleep. This turns off the wake switch. So there's a wake switch in the brain. It's a chemical location on neurons. And what they do with this is they say, well, if turning on the sleep switch isn't working, let's turn off the wake switch and see what happens. And so it sounds like a really good idea. We turn down that activity, then natural sleep kicks in, which is what we're trying to get in the first place. It's very expensive, well over $300 a month. Most insurances don't cover it. The few patients I've had, and mind you, this is not science because it's a handful of people, it hasn't done much. But just so if you hear about it, it is so far in my experience not a miracle drug. The theory was great. Obviously it works to some extent because it got approved by the FDA, but it's not a miracle. Hormonal therapy, well, they don't usually think about that as a sleeping pill. Menopausal women, there's a lot of changes that happen. I mean, I'm speaking to the audience, but disruption of sleep is very common. Mood changes, hot flashes, just general insomnia, the circadian rhythms get out of whack. There was a study that came out, gosh, 8-10 years ago called the Women's Health Initiative. Prior to that, we thought hormones were the fountain of youth. Every woman over 50 should be on hormones. It's good for preventing cancer and all these beneficial effects and makes you feel good and all that. We never really studied it. Kind of like how many hours do I need to sleep a night? We just said this is what it is, and then we studied it. What they found in the Women's Health Initiative is these things cause more harm than good, maybe higher risk of certain types of cancers and blood clots and heart disease. So then the pendulum just went crazy the other way. Oh, we got to get every woman off hormones. We made a lot of women really miserable really quick. So thankfully the pendulum's kind of come back to the middle again, and this is a very appropriate treatment for women who have menopausal related insomnia. It works, we use low doses, the risk is very small, and again, remember the risk of not sleeping. So it's the right treatment for some patients. And then the home remedy, the nightcap, alcohol. So alcohol has a lot of really unearned reputations. Oh, it's good to warm you up if you're cold. You're all mountain folks, you know, don't do that, right? It dilates blood vessels. It makes you feel warm while you lose your body heat and become hypothermic. It also promotes light sleep. So you'll have your nightcap, oh, I feel relaxed, you want to fall asleep. The problem is it interferes with deep sleep. It disrupts deep sleep. So you get that tossy-turny, like, oh, I'm just tossing and turning, I'm kind of sleeping, but not really. Alcohol should be out of your system by the time you go to bed. If you like to have a glass of wine, you should have at least 2 hours before you go to bed. If you have 2 glasses of wine, at least 3 hours before you go to bed. The DMV's got a nice chart you can get that about, like how long it takes to get rid of alcohol in your system. Alcohol is bad for sleep. So what are the solutions to insomnia? We kind of talked about all this stuff. You look for primary sleep disorders because all insomnia is not the same. There's a myriad of causes. Treat primary medical problems. If pain's keeping you awake, a sleeping pill is not going to help you sleep. You have to treat the pain. And so you got to identify what is the cause. Sleep hygiene, I'll stop now, sorry. But regular exercise, caffeine, alcohol. I didn't talk about nicotine. Thankfully, we're in a state that there's a very small percentage of smokers. Nicotine's terrible for sleep. It's a stimulant, right? That's why people get addicted to it. It releases dopamine in the brain. We get excited. It's not wonderful for sleep. The sleep environment we talked about, the 3 Labradors, 2 cats, and a hamster, they need to be somewhere besides the bed. And then when all else fails, we can do these things. I try to use sleep medicines for most of my patients as a transition while we employ some of these other things, some of the other behavioral methods, and then hopefully get them away from that. Herbal remedies, hey, if it makes you feel good and they're safe, sure.
Can I ask a question before you
course.
go back to the other screen?
Sure.
Please? Positioning.
hmm
What do you mean by positioning? Like, is there a way of sleeping, laying in your bed, starting out in your bed that's better than, you were talking about the sheet marks on your face kind of thing?
Sure.
Is there a way that you should try to gear your body into sleeping when you go to sleep at night?
Yeah, I didn't really expand on that. I probably should have. It's very difficult because, say, for instance, your husband, he snores on his back, but that's his best sleep position. So you have to kind of find some kind of compromise. Sleep preference or sleep position preference is really one of these things we just don't understand. Some people like their bellies, some people like their backs. And the idea was not to be forcing yourself into some other position that you're not comfortable in because of whatever reason, or if there's some type of orthopedic issue. I got a bad shoulder, I like laying on my right side, but my right shoulder is bad. There's ways of getting pillows under it, so you can still get into your preferred sleep position without being uncomfortable. So yeah, I didn't expand on that, but does that make sense?
Yes, it
Yeah.
does. Second question on that same screen.
Yeah.
Once you've been through menopause for X amount of years, you don't have the option for hormone replacement therapy if you've never been on it, correct?
No, you can, absolutely.
You can?
Mhm.
I thought once you went through menopause, if you didn't do hormone replacement therapy, you were kind of out of luck.
No, not at all.
Are you a sleep guy saying that, or are you?
Am I an obstetrician, gynecologist, endocrinologist?
Right.
No,
Exactly.
I'm not. I'm not. Yeah, and so yeah, again, there's a lot of concerns, and a lot of times, more often than not, I would do this in conjunction with the patient's gynecologist to say, hey, is it okay if I put Mrs. Smith on X and Y? We're using much, much smaller doses, and one of the problems we had with hormone therapy early on is we give huge doses. We do a fraction of that now, so it's just enough to offset the symptoms. And I'm not aware of any reason that if you've been in menopause for 5 years that you can't get on these things, because women do.
Okay.
But again, when in doubt, talk to the person who does. And I have a good relationship with our gynecologist. And if I'm not sure, she had this years ago and she had this surgery, I'll call them up and say, hey, this is what I'm thinking, this is the dose I'm thinking about, because collaboration is really important.
Okay. Thank you.
Yes?
What about andropause?
I'm sorry?
Andropause
Andropause.
for men.
Oh, androgen?
Yes, I was called andropause, when men go through.
Menopause, andropause, I got you. Yeah, thankfully that tends to have less effects on sleep, not nearly as much as in women. Testosterone replacement is a very controversial topic. And interestingly, testosterone in general is not good for sleep. It tends to be an activating kind of hormone, that fight or flight manly thing. And by the way, now that we're on the topic almost of sleep apnea, if you have sleep apnea, it'll make it worse. Did you have?
Physiologically, is there an ideal position to sleep? Your feet elevated, your neck at a neutral level?
Comfort's the most important part. Again, people have exerted a lot of scientific time on trying to figure out what is the difference in sleep positions. Nobody's really come up with an answer for it. I sleep on my right side. My wife sleeps on her left side. My dog sleeps on his back, and we just don't know. So again, I probably should have expanded a little bit more on positioning. Positioning is to the position of comfort and adapting your position to maladies that may keep you from your preferred position. Some people are just tops in bed. They're just spinning all night, but they sleep well, and we really haven't explained that. So sleep apnea. 30 years ago, if I put this slide up, people go, what? Sleep apnea, what's that? Now virtually everybody knows what it is. It's finally coming kind of the forefront, and it's extremely common. And this is a very typical scenario that gets, oops, that patient in to see me. What is it? It's common, it's dangerous, easily recognizable, and treatable. So these are the common symptoms. This is just classic. This is one of the easier things I do in my practice is identify sleep apnea, because usually when they come in, they already know they got it. It's usually the bed partner saying, oh my God, he snores so loud, the paint comes off the wall. And then he stops, and it's terrifying. And I timed it 40 seconds, he doesn't breathe. And oh my God, he's falling asleep. We're driving to the coast, and he's going across the center line. Patient wakes up, morning headaches, dry mouth, moodiness, memory problems. Again, anything that disrupts your sleep is going to create those things. And then accidents happen. And I've had, true story, 2 patients walk into my office bandaged up from the rollover the day or 2 before. I said, okay, it's time to get this looked at. And there's a significant number of motor vehicle accidents that are attributable to untreated sleep apnea. Now, the federal government has mandated that every single commercial driver gets screening for sleep apnea because a lot of these big rig accidents are due to excessive sleepiness. I mean, it kind of fits. I mean, you sit in a truck all day, you drive, you get overweight, you develop sleep apnea, there's nothing to do but eat. And these guys are driving 40-ton vehicles. So it's a big deal, and now everybody's paying attention to it. How common is it? Well, it depends on how you define it, kind of like the melatonin question. Well, which melatonin, and how do you define what is sleep apnea? So if you look at an AHI of greater than 5, so this is the number of times per hour on average somebody quits breathing. If it's more than 5, we identify that as sleep apnea. That is setting the bar really, really low because, probably half people in this room may have an AHI of 6, right? But does half people in this room have sleep apnea? Yeah, probably not. So you go to sleep apnea syndrome. So these are folks that have higher AHIs with daytime impairment. Those things we showed on the last slide. How common is it? Well, it's less common in women than men, and it's partially the way that we're built. Testosterone is bad for sleep apnea. But if you put this box on top of this box, it's going to be taller than this box. And how common is asthma? Who doesn't know somebody with asthma, right? It's very, very common. Estimated 22 million Americans. That's quite a few. And the big part, the part that I'm worried about, 80% of them are not diagnosed. Why does this happen? Well, if you get really gross and you put somebody's head on a bandsaw right down the middle, right? And then you look at it from the side, this is what we're looking at. So this is the tip of the nose, that's the mouth, here's the tongue, those are the nasal turbinates, the ear, the spine. So in normal open airway, here it is. It either goes through the nose or in the mouth, down to the trachea, and we breathe. You can see it's already a pretty tenuous situation. You got gravity working against you, you got all this floppy loose stuff in here. And in people with sleep apnea, first thing that happens is all this stuff starts rattling around, right? It's so close, it vibrates. That's what creates the snoring. And it can also be the tonsils, which really aren't illustrated here. Whoop, I just did that again. Next time, don't give me the remote control. So that creates the snoring. And then when we get in deeper phases of sleep, one of the characteristics of REM sleep is we lose muscle tone. If you ever picked up an infant that's sleeping, right? You pick them up, they're all floppy. There's no muscle tone. That happens to us as well in sleep. So we lose a little bit of muscle tone, and then boom. Tongue drops back, the soft palate drops back, airway's obstructed. Now the brain's in a real predicament. I can either breathe or I can sleep, but I can't do both. So the brain sends a stimulus, it wakes up, the gasping happens, that's what the bed partner observes, and this can happen over and over and over, 30, 40, 50 times an hour. I've seen patients over 100 times an hour. While that's happening, the oxygen levels are plummeting. I've seen saturations as low as they'd be on top of a 25,000-foot mountain. And this can happen 30, 40 times an hour. So you wonder why it's associated with all these things. And these are all very real things. You want to get a man's attention? Say, hey, this is what it's causing. They'll be in the sleep lab that day. High blood pressure, obesity, drowsiness, fatigue, diabetes, motor vehicle accidents, job impairment, arrhythmias, heart attacks, strokes, headaches. Bob died in his sleep last week. What happened to Bob? We don't know. He just died in his sleep. A lot of these people actually have undiagnosed sleep apnea because, again, remember the physiology of this. The airway's completely closed. They're strangling. Their oxygen saturations are dropping. And a lot of folks that actually die in their sleep may have undiagnosed sleep apnea. There was a very renowned football player, blank on his name, White. He was a reverend, played for the Green Bay Packers. Reggie White, thank you. He was diagnosed with very severe sleep apnea. He was treated. I'm not sure how this made in the news because it was without medical privacy. He decided not to treat it, and then he woke up dead. I think he was like 42, 43 years old. He woke up dead. No more reverend. This thing, pulmonary hypertension, dementia, memory loss too. I've had the neurologist send me a lot of patients. This patient's just not got good memory. They're having trouble functioning. It's not a primary neurologic problem. It's chronic sleep deprivation. So this is what we do in the sleep lab. This is actually an older picture. Our sleep lab, true story, this is not a sales pitch, is much nicer than that. We just remodeled it. It's beautiful, all right? But essentially you go in, you get wired up, and we just see what happens with sleep. Because again, we don't know what's happening when we're sleeping. An insomniac, they know what's happening because they're not sleeping. A sleep apnea patient doesn't know. They can't tell you. This gives us the information. It also evaluates for some other things that could be disrupting sleep. And again, not routinely indicated for evaluation of insomnia. Every now and then we do, because we dig down and we say, oh, you're not sleeping because you're not breathing. Okay, let's go to the sleep lab. New technology. So I don't want to go to the sleep lab and spend the time, get all those wires on me. This is actually a really good option for people who are not medically complicated, people who don't have lung problems, who require oxygen, who have congestive heart failure, who have heart rhythm problems. Just your otherwise healthy person with a high suspicion of sleep apnea. This is actually the device we use. It goes on the forehead, there's a little nasal cannula, you sleep with it for 2 nights, and it's actually a very good device. And the technology in this stuff has come a long way. We're doing a lot more of these nowadays, A, for patient convenience, and B, insurance companies are saying, well, if you can get the same information for a third the price, that's what we want you to do. How do we treat sleep apnea? Well, you know, if you're grossly overweight, sometimes that helps. I've had patients that are just enormous, you know, 400 pounds. They get bariatric surgery, they lose 250 pounds, so sleep apnea goes away. That's pretty rare. Again, usually it's an anatomic problem. So CPAP, which again, most people have heard of, the way it works is there's a mask that's affixed somehow to the face. There's about 100 different masks out there. The best one is the one that's comfortable for you. They go in the nose, they go over the nose, they go over the nose and mouth, whatever works. But the principle is we just use air pressure to keep that airway from collapsing. So here it is collapsed, you put a little airway pressure in, and surprisingly, it doesn't take a ton of pressure to do that. It works marvelously. It's the gold standard. Does it take some getting used to? In a lot of patients it does, and that's the role of either a primary care doctor or somebody who's a sleep specialist. All the little problems you can have with this, usually we can address and usually we can make it work. There are a few that just say, no way, no how, I ain't doing it. This is kind of what it looks like in real life, and again, one of the myriad of masks out there. But you know, you can sleep comfortable with it. The machines and masks are much better even than 5 years ago because this is such a huge demand. You know, you find a need and you fill it. You find CPAP that's comfortable, usable, tolerable, people will buy it from you. This is something else that's relatively new. These have been around for a long time. However, they're now kind of coming into their own. They kind of finally figured it out. The basic principle is they're just using the upper jaw to pull the lower jaw forward. And there's a whole variety of ways of doing that. These are custom-built mouthpieces. This is one of the many models out there, but this is a simple model. It's just got a rubber band. Again, it's designed to pull the jaw forward. If you do that, the space in the back of the throat opens up because the tongue's attached to the jaw, right? You pull the jaw forward, tongue goes forward, opens up the space. These tend to be good options for people who can't tolerate CPAP and have relatively mild to moderate sleep apnea. That person that has 100 times an hour, this is not going to be enough. But it's a really good option. Again, this is getting more people into effective treatment for CPAP, or for sleep apnea rather. And that's the happy ending. So this is a notorious gunslinger from the Old West, John Wesley Harding. And this is a true quote. They tell lots of lies about me. They say I killed 6 or 7 men for snoring. Well, it ain't true. I only killed 1 man for snoring. See, he's not so bad. Interestingly, the law eventually caught up with him. He ended up going to prison, and for some reason only served like 7 years. He killed scores of people. He got out of prison and he became a lawyer. He must have learned something in prison. And then he had a little kind of spat with somebody on the street, and the guy says, do this or I'm going to shoot you. And when John Wesley Harding says, I'm going to shoot you, you say, okay. But somebody else walked up behind him while this was all going on and put a bullet in the head. And that was the end of him. So anyway. Hopefully that's not all of you. That's some of you. I caught a few of you nodding off, but that happens. Yes?
So I saw on Facebook there's a new thing called Winix, I think, where you don't have to have any tubes.
Mm-hmm.
Mm-hmm.
Yeah, I haven't had any experience with it. I'm familiar with it. Essentially, it's a suction cup. So your tongue goes in this thing, and it uses suction, and then it uses your front teeth as an anchor to kind of hold it in place. I haven't had a lot of experience with it. You know, the tolerance, I would imagine, would be somewhat difficult to have something sucking on your tongue all night. But there are some new innovations. You know, people are always looking for a better way to do this. And frankly, I just pray for the day when we don't have CPAP, when we have something different. There's a newer device called an Inspire device that's starting to gain some traction. And essentially it's a pacemaker, and it's surgically implanted in the chest. It's got 2 leads. One goes down to the chest muscles, and one goes to the nerve that controls the tongue. You turn it on at night with remote control. Time to go to sleep, you turn it on. The chest lead senses when you're taking breath in, and then the pacemaker sends a little impulse to the nerve in the tongue, and it moves the tongue forward. And you can adjust it to adjust how far the tongue goes forward. It'd be kind of fun at a party just to sit there and hit the thing. But they've looked at this, and it's actually holding up. People originally were like, nah, that's too gimmicky, it ain't gonna work. But it really is working. There's only a few specialized centers that do it. For my patients with bad sleep apnea and nothing else is working, could be an option. The closest center that actually is certified to do these is Stanford. The retail on the whole thing with surgery and everything else is about $40,000. So challenges with insurance. Yes?
I have two questions. Does CPAP have a side effect? And if a person with sleep apnea will use CPAP and has a pulmonary hypertension, will it hold it there? For example, mild hypertension, will it stop it there, or will it still progress?
Okay. So the second question, you're talking about pulmonary hypertension?
Yeah.
Yeah, so part of the work, pulmonary hypertension is a kind of poorly understood disorder. It's when the blood pressure in the lungs is elevated on the right side of the heart, not the left side of the heart, where we measure blood pressure here. It has a lot of consequences. It can be very dangerous and even deadly in some folks. Part of the workup for that diagnosis is doing a sleep test, because one of the things that causes pulmonary hypertension is low oxygen levels. The blood vessels in response to low oxygen constrict, the pressure goes up, oxygen levels go down, it's a vicious cycle. So for those folks that have pulmonary hypertension due to sleep apnea, CPAP is very effective, and I've had a lot of success with that. We measure their blood pressure in their lungs, we treat them with CPAP, 6 months later we re-measure it and can actually come down dramatically. The problem is pulmonary hypertension, the list of causes is about yay long, and just determining is it only sleep apnea or is it sleep apnea plus something else is kind of hard. And I forgot the first question.
Is there a side effect for the use of CPAP?
Yeah, there are a whole bunch of different things that can come up. Everything from nasal dryness, mask problems, erosion over the nose, air swallowing, claustrophobia, intolerance. And that's kind of what I was talking about. You don't just give somebody a CPAP machine and say, here you go, Mr. Smith, here's your CPAP, we'll see you next year. I see these folks back 2 weeks after they start. I give them a little tip sheet on all the little common problems, and there's solutions for most of those. Usually if the patient's motivated and we can address those problems early on, they actually do pretty well. But there are a lot of things that can occur with sleep apnea, and it's not, you can't really predict it. One person gets a sore on their nose, it's usually because they're not using the mask right or don't have the right mask. If they're swallowing air and they're working with big bloated stomachs, we'll have them prop the head of their bed up a little bit so the air has a way to get out. So there are usually solutions for those types of problems.
And I've slept at the hospital at the sleep study test,
Mhm.
and they're really nice there, very comfortable, they're very professional, and it's really easy. It's really easy, and I have to go to another sleep study test because I have a head cold, I couldn't really finish it. But Candace said I wake up 56 times in an hour.
Well, thank you for staying awake during this. Yeah. And thank you for the kudos on the sleep lab. Appreciate that. Yes.
You say 7 to 9 hours of sleep is what we need, and you break that up, like sleep 4 hours, and then get up for a couple hours, and then sleep another 3 to 4 hours.
Well, you know, you do what you need to do, and I've seen every sleep pattern you can imagine. The bottom line is if what you're doing is working, and you're functional during the day, and you're not tired, and your mood is good, do what works for you. Ideally, if you're having difficulty during the day or you're having maintaining sleep, it should really be fairly continuous. Because remember that circadian rhythm, that up and down cycle, you really want sleep to be during the down cycle. So if you're having wake time in the middle of the down cycle, the brain's getting confused, like, oh, this is up time, and it can really throw off the cycle. But again, especially as you get older, a lot of people adopt really bizarre habits, like, yeah, I go to bed at 8, and I sleep till 2, and then I get up and I read the paper for 3 hours, and then I go back to bed and I sleep from 4 to 7. If it works for you, fine, but you know, it's not ideal from a circadian rhythm standpoint.
Can you talk a little bit more about the difficulty with sleeping as you get older? Is it loss of melatonin production in our bodies, or?
Yeah, it's a lot of different things. There's a natural progression in the brain of these cycles and these stages of sleep. We're not sure why that happens. You know, we lose certain types of neurons as we get older, the brain atrophies. And then other things come into play. It's very uncommon to be in your 70s or beyond, not have medical maladies, you know, arthritis or, you know, heart problems or lung problems. And all these things disrupt sleep as well. Physiologically, we lose this thing called delta sleep, which is deep sleep. It's fun to look at on a sleep study because there's these huge waves, and kids have tons of this. And as we get older, it goes down and down and down. And that's part of the stuff that restores us physically. Well, here we are kind of suffering with the maladies of age anyway, and now we're losing that stage of sleep that restores us. So it's not a single answer. There's a lot of things that kind of go into it. And part of it is acceptance. Back to Steph Curry and Will Ferris, you got to understand as you get older, it's not going to be as good, but you can still make it as good as it can be.
Can we talk about the difference between a CPAP and a BiPAP?
Sure. So now we're getting a little more of the technical aspects of treating sleep apnea. So there's really 3 types of machines. There's a CPAP machine, a BiPAP machine, and an ASV machine. So CPAP was the first thing that came out. This came out in the early 80s, and interestingly, we still have the CPAP at Stanford. They have this called CPAP Museum. It's kind of a closet. We have all these various generations of machines. And interestingly, the first CPAP machine was a vacuum cleaner motor that was running backwards, so it was blowing instead of sucking, and it was attached to a fighter pilot mask. So you're like, okay, how did this ever gain traction, right? Current CPAP is absolutely nothing like that. We saw the picture. So CPAP stands for continuous positive airway pressure. It's a single level of airway pressure that's delivered the entire night to keep that airway splinted open. Some folks, particularly folks that have central sleep apnea, and talk about that very much, need 2 levels of therapy. So when the machine senses you're taking a breath in, it gives you a little extra pressure, and as you quit taking a breath in, it drops down back to that basal CPAP pressure. So as you breathe, you get a little higher pressure, it drops down to the basal level. There's a third type, which is relatively new. It's called ASV, which is really smart. This machine has a whole bunch of parameters we adjust, but essentially it's a smart machine. It adapts to you breath by breath. So if you're taking a full breath, it just gives you a little support. If you're taking a half a breath, it gives you the other half. If you're taking no breath, it gives you the whole breath. And these are parameters we have to set in the sleep lab. Don't use that a lot. People love it because it adapts to them like breath by breath. The problem is it costs 3 to 4 times as much as a CPAP machine. Anything else?
Is there any relation between sleep apnea and altitude?
Good question. It hasn't been really studied well, and one of the things that frustrates people, doctors who like science and live at altitude, all the science is done at academic medical centers. Where are all the academic medical centers? They're all at sea level, right? Harvard and UCLA and Stanford, they're all at sea level. By observation and some small studies, we know that sleep apnea tends to be worse at altitude. Certainly central sleep apnea, and that's a disorder where the brain does not send a signal to the body to breathe, is worse at altitude. And patients who are on CPAP tend to require higher pressures. And I think it's not really the pressure. I think there's less air per volume of space, and so we just need to push more of it in to get the same effect. But it does tend to be worse here. I have a patient, super interesting. We get downloads from these machines. They can tell you what's happening night to night. And when he's at sea level, his machine works perfect. He has no apnea. He brings the same machine, the same body, same mask up here, and it's horrendous. And we still haven't figured it out. I actually sent him down to Stanford because I couldn't figure it out, but it was the most dramatic case that I had seen. Yes?
You mentioned that 7 to 9 hours is pretty standard or what's required, as far as being healthy.
Mm-hmm.
Do you know some who are 4 to 6 hours been sleeping that way for X amount of years and function pretty normal?
Sure. Yeah, we call those short sleepers. And on the other end of the spectrum, there are long sleepers. There are some folks who just, for whatever reason, they need 10 hours, and they struggle and struggle and struggle because they're being shoved into this 8-hour sleep world. On the other end of that, we do have short sleepers. They're relatively rare. They're much more rare than we think they are. People go, I get by with 5 hours a night and I'm great. Well, that person's developing chronic cumulative sleep deprivation. So we force ourselves into that pattern. There are those very rare people out there, but they're really uncommon. Are you one of those guys?
Yeah, pretty much 5 to 6 is pretty standard for me. It's broken up. I get up several times.
Mm-hmm.
But I was just wondering if, and I'm pretty used to it. I get pretty tired, and I'll finally catch up with me, and I'll sleep maybe 6 or 7, or 7 maybe or more.
Mm-hmm.
Usually pretty steady. So I was wondering about the health, consequences or whatever would be associated with that for long term.
Sure, yeah, well again, remember first slide, all that stuff. And again, that is a dramatic slide and all those things are gonna happen to you. You're not gonna get cancer and fat and whatever else. But the telling thing in just that short history is the fact that you have catch-up nights. Remember the story I told you about the medical students that would torture and would deprive them of certain stages of sleep? So when you're chronically sleep deprived, eventually your body hits catch up where, oh my God, I need 7 or 8 hours. You may be a guy who only needs 6 and you're getting yourself 5 or 4. But the true, I'm fully functional on 4 or 5 hours a night people are relatively rare. The situation you're describing is a lot more common. Yeah.
I had cancer, and that was because I had too much estrogen in my body, and she gave me some medication called Insulin or something that I have to be on for 10 years.
Is it Arimidex?
Huh?
Arimidex?
Yes.
Yeah, Arimidex, uh-huh.
And I'm wondering if that's caused me from not to go to sleep sometimes.
Very likely, very likely. So that's an anti-estrogen, that's an estrogen blocker. So they're taking away every bit of estrogen that your body wants to
I have
see.
to be on it for 10 years. I said if I live to be 92.
Well, I hope you do. Yeah, and again, that's something we can work around.
Oxygen also, but I've had
Sure.
sleep apnea since I was 20, in my early 20s.
Mm-hmm.
And I was in the Bay Area, but up here I have to use a little oxygen.
Sure. Yeah, and again, you'd be one of those people when we talked about who should we actually use sleep medications, and you might be one of those people because we're trying to offset the adverse effect of another medicine that's messing up your sleep.
I can never wear the mask. I have to have the pillow.
You're not alone.
You know.
Yes?
Other than telling workers to quit night shift, what would you advise night shift workers to do with their, circadian rhythm and
Yeah.
sleep hygiene?
Well, it's really, really difficult. In patients, and I have these folks come in, hey, my normal sleep cycle is 10 to 6, but my job is 11 to 7. What do I do? The first thing I tell them is no matter what we do, you're not going to feel good. You're never going to feel, I'm in vogue, I feel good, I'm getting great sleep. That's not going to happen. So there's some strategies with circadian rhythm adjustments, and it takes a little bit more history. Typically what we like to see people do is come home, do a little wind down after their shift, say they're getting home at 7, do a little wind down, and then following that, they sleep for a period of hopefully 6 to 7 hours, and then they have a period of wake time before they start their shift again. But it's really variable. Some people say, no, I do much better at pretending it's night. I darken everything, I go to sleep at 3 p.m., and then I get up at 7 or 8 p.m. and pretend that's my night. But physiologically, circadian rhythm-wise, it's better to kind of do the thing I talked about, because that 2 p.m. dip, you want to be sleeping during that. So if you come home at 7, you're awake for a couple hours, you want to be asleep during that mid-afternoon dip while everybody else is at Starbucks.
Could you talk a little bit about sleep cycles,
Mhm.
90 minutes? And the time
Oh,
of the
the
cycle?
sleep cycles, yeah. So I didn't go into that. It's a little, probably too much basic science for a lot of folks. So yeah, there's essentially wake, stage 1 sleep, stage 2 sleep, delta sleep, and then REM sleep. And so typically we go through these in a fairly typical pattern. The typical pattern really depends on patient's age. It's very different for a 7-year-old versus a 17-year-old versus a 70-year-old. The most notable thing is that REM sleep, which is the more dramatic time of sleep, that's where we have those dreams. Those kids are like, oh my God, that dream was crazy. The nightmares, the violent dreams, the sexual dreams, the ones you're driving race cars, whatever. That tends to happen during REM, and REM is concentrated during the second half of the night. And that's why in the early morning hours, I just had this amazing dream while I woke up. People that don't dream say, I don't have REM sleep because I don't dream. Not necessarily true. But I'd have to show you some graphs, but it's kind of complicated. The lighter sleep and the delta sleep tend to progress and get more intense and more frequent as the night goes on, and then a lot of REM sleep during the last part of the night. I don't know if that answered the question. I didn't bring that slide.
Well, with respect to REM, is it more common that women have better REM sleep than men? I've heard that.
Yeah, there's really not a big gender difference at all, yeah.
Just 1.5% of women sleep worse than
1.5 times more.
Tryptophan.
Mm-hmm.
You mentioned that in the sleep hygiene,
Mhm.
glass of milk,
Yeah.
tryptophan.
Yeah.
What about tryptophan supplements, 5-HTP?
Yeah, to the extent that they've been studied, and again, it's hard to do studies because the dosage and the concentration and all that is just all over the map. It has very, very mild effects on sleep promotion. People always attribute their Thanksgiving, oh, I had this big dinner, it was all the tryptophan and turkey. No, it's because you sat and you ate for 3 hours and you drank 4 glasses of wine. So it does have very mild sleep-promoting effects. Unfortunately, that's usually not enough to offset some real serious insomnia. I have some patients swear by it, and again, same issue. If it's safe and it's not toxic and it's helping you, great, but it's not a magic bullet. We still need one of those. All right. Well, thanks for all the questions. Thanks for your attention.